Hi, my name is Dee Eaton. I'm the Senior Clinical Editor at Nursing Times. This video is the fourth in a 5-part series explaining how support surfaces can be a vital tool in preventing and managing pressure ulcers. In video 1, we looked at the fundamental science behind support surfaces and what causes skin damage. In video 2, we looked at static support surfaces, foam, hybrid and semi-dynamic systems. And in video 3, we explored dynamic therapy mattresses. In this video, we will examine fluid immersion and air-fluidised systems. When these therapies are engaged, they provide support surfaces that are in constant motion. However, confusingly perhaps, they are not categorised as dynamic support surfaces. Rather, they are a new wave of specialist therapies in their own right. Both of these systems are reserved for the most complex patients where existing technologies cannot accommodate certain clinical needs. Due to their specialist nature, these therapies also offer by far the most evidence for their use. A Cochrane review published in 2001 concluded that good evidence from randomised controlled trials suggests that air-fluidised beds may improve pressure healing rates. European guidelines also state that air-fluidised systems are characterised by relatively high levels of envelopment and immersion compared to other support surfaces. When we look at the thesis behind this technology type, the science is very simple. If you imagine yourself floating in a swimming pool, all areas of your body are fully immersed and you do not feel weight and gravity compressing against you. Essentially, both air-fluidised beds and fluid immersion simulation therapy systems aim to replicate that buoyancy and alleviate any compression. For our patients, it would feel like they were lying in a body of fluid. When your body is lying on a standard hospital mattress, subcutaneous tissue and muscle is compressed and distorted. As the capillary network that feeds the skin and subcutaneous tissue is also compressed and becomes distorted, this makes it much harder for vital oxygen and nutrients to reach the affected area. These fluid systems are beneficial for patients because their skin and soft tissues that are in contact with the bed are not compressed, blood flow is not compromised, and thus it enables better perfusion. This in turn allows adequate blood flow to tissues to accelerate wound healing and reduce the incidence of pressure ulcers. Both air-fluidised systems and fluid immersion have comparable outcome studies in terms of what they achieve. However, their mechanisms slightly differ. This is an air-fluidised bed. For demonstration purposes, we've removed the cover so you can see its inner workings. You can see it as a large structure with a motor attached. When it is switched on, air is sucked in, heated and pumped into its base. The support surface in contact with the patient is thin, and underneath there are millions of tiny silicon beads the size of sand grains. As hot air is piped through, the beads move and bubble, creating an artificial fluid environment. For a patient lying on top, it can feel like they're floating in water. They feel buoyant. If we switch the bed on, you can see what happens when I float an object like this apple on it. With me is expert nurse Lorraine Thursby, who leads a tissue viability service at George Eliot Hospital NHS Trust in Nuneaton and who has a lot of experience with fluid systems. Lorraine, so how long have these beds been around and what sort of patients do they benefit?
Air-fluidised therapies have been around really since the mid-1970s. They are fantastic and have been well used in burns, plastics and spinal injury patients. With spinal injuries though, it is really important that the spine is stabilised before they go on to air-fluidised therapy. They are a very effective therapy because of their nature of fluidity, but they have some drawbacks. One is they weigh in excess of a tonne, they're very cumbersome. So logistically you have to think about where in an organisation they can go, so there are some structural challenges, especially in an older organisation. Also, if it has to go in a side room, there's some things that have to be considered from an infection control perspective. Also, the fact that they run a little bit above ambient temperature, so the patient can get extremely warm. It does have specialist servicing and it needs specialist decontamination and laundry.
Has there been any research to compare these beds to conventional therapy?
So, a randomised study by Alman et al. In 1987 looked at 140 patients with pressure ulcers on air-fluidised beds versus conventional therapy. The study took part over 13 days. What they demonstrated was the surface area of the pressure ulcers reduced by 1.2 centimetres squared on the air-fluidised bed, but by comparison, the patients on the conventional therapy, their pressure ulcer size increased by 0.5 centimetres squared over the same period of time. The study actually concluded that air-fluidised beds are more effective. So it's not only the benefit of the healing that we saw on the air-fluidised beds, but also the benefit of immersion therapy for comfort for the patient.
Fluid immersion simulation therapy offers us an alternative to an air-fluidised bed. That's a more recent technology, isn't it? Lorraine, can you tell us about it and its interesting origins in the US Navy, I believe?
Yes, fluid immersion simulation therapy was first introduced into the UK in 2012. It has a great benefit because, unlike air-fluidised therapy, it's a mattress that goes onto the bed, so that's a win straight away. You're right in saying about the US Navy. They used to transport dolphins on reconnaissance all around the world, and many of these poor dolphins died in transport. What they found on post-mortem examination was they had circulatory distress and internal organ trauma, a crushing type of injury. This was down to the gravity exerting pressure and vertical shear forces on the internal organs while they were transported. Now, these dolphins were a vital part of the US military, so trying to find a way to transport them safely was really important. So those naval engineers in the US developed a support system to allow them to recreate the buoyancy of the water whilst transporting the dolphins. So they recreated this natural dolphin environment, and it's that technology that has been translated now into the mattress.
So what benefits does this therapy offer?
The main benefit is buoyancy. It provides really good conditions for the patient and helping nurses look after the patients with pressure damage. There is a wealth of evidence around this therapy, in excess of 2,000 clinical outcomes and scientific evidence to support using CT scans, laser Doppler fluorometry to show that how it supports the skin and reduces that compression on the skin surface. It alleviates some of the drawbacks of the air-fluidised beds. So from the practical perspective, it has a big benefit because it's not the cumbersome big static unit of air-fluidised. It is a mattress system that can go on your normal hospital bed frame. From a patient experience point of view, it has a lot of benefits. The fact that it is on your normal bed frame, you still get the full contour of the bed frame. This has the benefit for the patient. They can still have their treatments, their respiratory function can be improved because you can sit them up better. You can pass NG tubes if that's needed without compromise to the patient. There are a lot of functions that you get from having the bed frame and the mattress combination that you certainly wouldn't get with just an air-fluidised unit. So it does have a lot of benefits using fluid immersion simulation therapy.
So when exactly should a patient be considered for air-fluidised or fluid immersion simulation?
When you're looking at the patient, you have to look at them as an individual, so the clinical indications can vary for these patients. However, some of the situations for these technologies are really well suited for intensive care areas, especially for those patients that are sedated or ventilated, or even if you have to nurse them prone, because these are positions that can put a lot of intense pressure on very, very vulnerable and compromised skin because of circulation issues. So it's a challenge where repositioning is difficult or sometimes deemed impossible. Other situations where this technology can be used are things like the burns and plastics to promote wound healing, such as flaps, graft surgery and pressure ulcer repair. Vascular surgery, because the patients do have a compromised flow. Trauma and orthopaedic units, things like frailty, neck of femur fractures, where repositioning can be very, very painful. Patients with multiple areas of tissue damage, such as category 3 or 4 pressure ulcers. Deep tissue injuries or unstageable damage can be problematic. Paediatric or plus-side patients where the skin is extremely vulnerable. And of course, spinal cord patients, but again, after the spine has been stabilised. Dignity and improved comfort is essential for looking after our patients, and it It's not only a desired outcome, it's what we should expect for our patients throughout their journey. And this is really important when we look at end-of-life care. These types of fluid systems also help with patient pain management and comfort, which are really key to the patient, because it can be distressing, especially to visitors, relatives, seeing their loved ones in discomfort. It has been acknowledged within the guidelines that these support surfaces can be indicated for pain management or indeed in sensitive scenarios.
With the wealth of evidence and testimonies around these technology types, they should always be considered for difficult to manage and complex patients where existing technology, such as a dynamic therapy, is not suitable or working well for the patient. Speaking to your TVN or an industry clinical advisor is recommended before prescribing this therapy type to ensure it is appropriate and justified. So Lorraine, are these therapies always a step-up therapy?
Yes, it's true. Air-fluidised and fluid immersion simulation therapy can be a step up from a dynamic therapy system. It's usually when a patient's condition changes and they need to meet certain criteria. It's important that you actually check your local hospital policy for the organisational protocol about your equipment and step-up processes and step-down processes. Always look at the general condition of the patient as a whole. So look at the general decline in their clinical condition, how their comorbidities have become more unstable, what their oxygenation could be like. Consider using it as a preventative measure as well, because these patients are at great risk. Pain is key. If patients can't tolerate being moved and repositioned, then this has a significant benefit for the patients. It is also important to consider, it could be that they're elderly, they have rheumatoid or joint pain. It could be that they have metastatic disease pain. Consider their needs, what makes it easier for them to be looked after. They may not tolerate alternating support surfaces in such conditions, and that's why the Dolphin, the fluid immersion, is a big benefit. Also to consider from a prevention with underweight patients, those that are very emaciated or cachexic, it is important that we look after their vulnerability of their skin. They have very little adiposity, so their vessels are going to be compromised really quickly. If they have contracted limbs, actually reposition them comfortably is going to be virtually impossible. So those handling situations, fluid immersion therapy really comes into its own. They have benefits too, not only to the patient's treatment and hospital stay, but from an organisational perspective, because if we look after those patients, we do not give them additional skin breakdown, then actually we're looking at a reduced length of stay. A fluid immersion simulation therapy should have an auto-firm or max inflate function. For this therapy type, it is even more critical that this function is utilised every time that the patient is moved, repositioned or mobilised. This is because on fluid immersion simulation surfaces, the patient is incredibly immersed, even more than a traditional dynamic mattress. And trying to move them without this function pressed means that you are dragging the patient and potentially exposing them to shear forces. So please always remember to facilitate this. On an air-fluidised bed, the positioning of the patient is slightly more complex and should be carried out by following the manual handling team's own policies.
And when does a nurse know when a patient is ready to step down?
I'd advise that they need to be regularly assessed to just make sure that they're actually meeting the stepping down criteria. It's important that you actually take these patients off at the right time. Too soon, and then the patient could deteriorate, so you're actually causing more work for yourselves and you're putting the patient at greater risk. Too late, that could still also become a problem, because then the patient has become reliant on the benefits of the high specification of this type of therapy, and this could impact on rehabilitation.
It is of course important to regularly assess patients. Such an assessment should include considerations such as the patient's mobility. Are they still dependent on a staff, or can they now self-mobilise, for example? Also, it should include the status of their existing skin damage. Is it healed, improved or unchanged? These are all factors to review when making the decision to step down a patient from fluid immersion or air-fluidised. In this video, we've demonstrated how fluid immersion simulation therapy mattresses and air-fluidised beds work. We've shown you inside to explain how they work. These technologies should be regarded as the therapy of choice for our most complex patients and where existing technologies cannot accommodate their clinical needs. In the next video within this series, we will explore support surfaces for two particular groups of patients, children and plus-size patients.